Everybody, welcome. So I'm going to talk about solid tumor cell therapy today, and then Noffar is going to talk about hematologic malignancies. I'm going to talk about three different sections: what's approved, the updates at ASCO, and then what we have available here. So starting with approved therapies, one of them is something called TIL therapy. I think probably a lot of people are familiar with it, but basically, sorry about that. Okay, so in TIL therapy, what you do is you resect a tumor from a patient, and the idea behind it is that the T cells in that tumor probably are more likely to recognize the tumor, and yet they can't function very well because of the tumor microenvironment. So you take them out of the microenvironment, isolate the T cells, grow them up, and you do that with IL-2 to make them super activated. In the meantime, you lymphodeplete the patient, and then you reinfuse it into the patient and give them high-dose IL-2. And this is an approved therapy for melanoma, and these are sort of the most recent data on this. And unfortunately, I don't have the reference here. It's Chesney, Journal of Immunotherapy and Cancer, 2022. But you can basically see that there are a lot of responses. There's about an overall response rate of 36%. These are mostly in people who've already seen ipilimumab and nivolumab, some of whom have seen BRAF inhibitors and MEK inhibitors if they have those mutations. And the duration of response, 8 months. Overall survival, about 14 months. And so this is an approved therapy. We do it at Yale. It's not done everywhere because it's complicated and difficult to do this. It's an in-house procedure basically mostly because of the interleukin-2. All right, so that's one thing that's approved. We don't have a ton of things approved, so here's the only other thing. And I have to tell you a little bit about T cells first. So this is something called a TCR-T therapy, and it's for sarcomas. And just be aware, because this is important, it comes up later, in fact, that when a T cell receptor recognizes something, it doesn't just recognize the antigen, which is presented to it by a cell. It has to recognize it within something called MHC. And so it recognizes the combination of this, okay? And it really only works if the antigen is presented by a specific type of MHC, and we have different MHCs within us. Similar to the TIL therapies, the TCR-T therapies also involve taking cells out of a person, but instead of taking it out of a tumor, you just pherese their T cells, activate them, transduce them with the specific T cell receptor that you want that will respond to something particular, and then expand it and reinfuse in the patient. And we also lymphodeplete these patients, but they don't need IL-2 afterwards. So the one therapy, TCR-T therapy that is approved is for synovial cell or myxoid round cell liposarcomas. As I said, it only works if it's recognized by a specific HLA type, because the TCR that they put into these cells only recognizes this thing called MAGE-A4, an antigen, and it only recognizes it when it's presented by the specific MHC type called HLA-A2. It's actually O201. And what they found when they did this was a response rate of about 37%, duration of response 8.3 months, and a median survival of 17 months. Again, forgot the reference, it's D'Angelo, Lancet 2024. But this is sort of the first of its kind, and the first engineered cell therapy for a solid tumor. So very exciting in that this might mean there are more to come. All right, let's move on to what happened at ASCO this year, since this is an ASCO update. And before I do that, I'm going to talk about a little bit about the difference between antibodies and T cell receptors. And the reason for that is to talk about sort of how these therapies work and what's required. So as I said, the T cell receptor is this thing on T cells. It only recognizes proteins. It only works if the antigen that is the part of the protein is presented by this thing called MHC, or in humans, HLA. And it requires co-stimulation, all right? And what people may not know is that the T cell receptor interaction with its prey is much, much weaker than antibody antigen reactions, okay? About 1,000 to 10,000-fold weaker. So someone had the idea that since T cell receptors are so much weaker, since they require MHC, maybe we could take a T cell receptor and instead of using the T cell recognition domain to recognize its target, we could just chop that part off and stick on an antibody, okay? And they did that and they called it a CAR, because it's chimeric. It's got the T cell receptor signaling on the inside of the T cell, and it's got an antibody on the outside. And that is what CARs, in fact, are. If people are not totally familiar with that. So they thought, this is a great idea. So we'll have a T cell receptor on the bottom end and the back end, inside the cell, antibody on the top end. They made it, and it didn't do anything. Okay, and so then they thought, what's wrong here? And remember what I said is that T cells, in order to function, they need something called co-stimulation. They need another signal. So they thought, oh, maybe we just stick that second signal onto the receptor, it'll work. And this was the magic. So these are all these CARs that you've seen approved for leukemia, lymphoma, myeloma. Okay, they basically have this structure, all right? And there are sort of two common co-stimulatory things they use, CD28 and 4-1BB. And now they have fourth generation ones that are called armored CARs, where they put other genes into the cell to make them very engineered. So, and CAR T, much like TIL, again, you isolate T cells, activate them, transduce them with a specific CAR that you want to put in, expand them, and reinfuse into the patient after lymphodepleting the patient. Okay, so the first new thing I'm going to talk about in solid tumor cell therapy from ASCO is the ALLO-316 or TRAVERSE study. This is updated results from a phase 1 study on an anti-CD70 CAR in clear cell renal cell cancer. Very interesting in that it's also off the shelf. You're not actually taking it out of the patients. They have a separate T cells they're putting in. You might say, well, can you really just throw random T cells into a patient? The answer is no. But what they did is this particular T cell, it kills things that have CD70 on it. And one of the things about CD70 is it's on a lot of clear cell kidney cancers, but it's also on T cells. So it turns out that either by luck or on purpose, they designed something that when T cells from the body come to kill it, they get destroyed actually by the cell product itself. All right? I'm not going to go through this in detail, but it's a basic phase 1b design. And note for people who are interested in kidney cancer, a lot of lines of previous therapy. These are patients who'd been heavily pretreated. Often they were getting greater than or equal to 3 tyrosine kinase inhibitors. And again, a lot of them had received, most had received some sort of immune checkpoint inhibitor. They got sort of the standard side effects that you expect from these therapies, which I haven't really talked about. But remember, we're lymphodepleting these patients, and we're putting in a very, very active anti-immune agent. And what they get is they get exactly what you'd expect from people who have been lymphodepleted early on, and they also can get something called cytokine release syndrome that probably a lot of you are familiar with. But notably, most of it really was grades 1 and 2. So this is actually a pretty well-tolerated therapy. I think the key point for this study is that in people whose renal cell carcinomas expressed a lot of CD70, the target of this, what they found is a 31% response rate. And here are the actual plots. So you can see there's actually, looks pretty good. And there are a number of patients who've responded for a while. And I can show that here also with the swimmer's plots. So, in summary for this trial, response rate of 31% for people whose tumors express the antigen, pretty safe. The profile was manageable, consistent with standard lymphodepletion and active CAR T cell therapies. And basically, the cells stayed around and weren't rejected by the immune system, probably because of the fact that they probably kill off T cells that come to attack them. So this was people were very interested in this particular trial. It will be moving on to a later phase. We will have it at Yale as soon as they open that phase of the study. Okay. Second one. This was very highly anticipated, OBX-115. This is a TIL therapy, but what they've done is, one of the big problems with TIL therapy is giving people the IL-2. And it's difficult. You can only do it for a short period of time. It has to be done in the hospital. What they've done is they engineered IL-15 into the product, and it only makes the IL-15 when you tell it to by giving people something called acetazolamide, which will turn on the gene. Again, this is what TIL sort of is, just to remind you. This is their system, and again, it's actually quite similar. You get tissue, they manufacture it, they infuse it, and then in order to sort of give the interleukin, they just give people acetazolamide, and they give it multiple times. And you don't have to give patients IL-2. And the result is, and by the way, the patients were heavily pretreated. This is, again, melanoma, sorry, similar to regular TIL. Heavily pretreated, almost everybody got anti-PD-1, anti-CTLA-4. The side effects were actually pretty good. The red are grade 3s or greater, so you see there's very little of that. And most of the toxicity is just from lymphodepletion, so much better tolerated in a way than regular TIL. And the responses for the highest dose level, which is what's going to move forward, very small numbers, but 4 out of 6 responses, which is pretty exciting, although, again, very small numbers. And you can see that they're kind of deep responses, including 1 CR, and 3 out of the 6 of those we haven't yet, the median time of response has not yet been reached. So this is very exciting, very early, but very exciting. And I'd say the same thing is true for the TRAVERSE trial, early but very exciting data. Let me move on to what's going on here. I got a minute left, so I'm gonna go really fast. One is an anti-HER2 trial. This is a CAR T trial, also off the shelf, so you can go directly into patients. I'm not going to go through all this, but this is really just to say that these cell therapies that we're doing are extremely engineered. They're not just CAR T cells. They're CAR T cells that they've modified in many different ways genetically to make them better tolerate the microenvironment, get to the tumors better, et cetera. So for people who have HER2, we have this trial. It's for people who've already been on many, many HER2 therapies, so it's we're welcome, anything, as many lines as you want. In fact, at least 2. Another one, I'm going to go again very briefly, is Briacel. This is also for breast cancer, late stage. This is actually a very, very easy trial for patients in that it's just a subcutaneous injection of these cells that have been engineered to, they're breast cancer cells that have been engineered to be immunogenic. And Adriana Khan is running this trial. And lastly, we have a basket trial for, and this is again a TCR-T type. So it's for patients who have a particular HLA type, HLA-A*02:01, and there are many antigens that are actually being studied. So the key here is, rather than going through it, because I'm out of time, is if you have questions and if you think any of your patients may be good for these trials, please contact us. This is our contact information. You can text me or call me or email me or our team. So I think I made it within, just over, sorry. All right, thanks a lot, folks.
Out to hear about cellular therapies in multiple myeloma, Dr. Noffar.
All right. Oh.
And if we have time, we'll do a few questions at the end.
Hi, everyone. Let's get this started. All right. So today I'm going to be talking about a few of the updates in T-cell redirection therapies in the myeloma world. For time purposes, I'm only going to be talking about a few. So just to set the stage and give you a little bit of a background for those of you who don't treat myeloma on a regular basis, I want to review the natural history and progression of myeloma. So when someone first gets diagnosed, they are called what we call newly diagnosed. They get upfront treatments, and typically the duration of response with upfront treatments is the longest duration. And with each subsequent relapse, they get second, third, fourth, and so on line of therapies, the duration of response is typically shorter and shorter. And we define early relapse as having 1 to 3 lines of prior therapy and late relapse as more than 3 lines of therapy. And that's important to understand the clinical trials and FDA approvals. Now, the outcomes of patients with late relapse was really poor until 2021. So what happened in 2021? We had the approval of CAR T-cell therapies. So there are 2 approved CAR T-cell therapies targeting BCMA, and the first one was ide-cel, and the second one was cilta-cel. I'm not going to be focusing my talks on ide-cel, but we'll be focusing on cilta-cel. But just to remind people, historically, the median progression-free survival for late relapse who get another line of therapy is usually around 6 months, and often patients pass away within 1 year. So just keep that in the back of your mind. So Cilta-cel was approved for late relapse based on the phase 1 study of CARTITUDE-1. Now, this is not new, but I just want to refresh your memory here. So this was in late relapse, and you can see here, this was very heavily pretreated populations with a median line of 6 prior therapies. And I point out some high-risk features here. So about a quarter of the patients had high-risk cytogenetics, and 13% had extramedullary disease. And why do I point this out? Because these are factors that typically predict shorter duration of response. You can see here the construct is an anti-BCMA, there's 2 binding domains. So why was this approved? Really outstanding response rate, almost 100% response rate. Only 1 patient did not respond, actually was not evaluable for response, but did have a benefit. And many of them, most of them had deep responses, which is important in myeloma, with a median PFS of about 3 years. So remember, this is unheard of in this patient population. Now again, this is not new, just a refresher. What was new at ASCO was the 5-year follow-up. And you can see that a third of the patients remain in remission at 5 years, all right? And these are patients who are not on therapy. So after CAR T-cell therapies, you are just watched with observation. So these are patients 5 years without getting treatment, alive and progression-free. And some of you guys might think, well, isn't this a cure? It actually led to the New York Times article, From No Hope to a Potential Cure in a Deadly Blood Cancer, just to show you the impact. Now, these patients were enriched with a lower tumor burden and a more naive T-cell phenotype in the CAR T product. So that is important. But what they did not see is if you look at the high-risk features of high-risk cytogenetics and extramedullary disease, those long-term responders had the same percentage of patients having these factors as those that were progressed earlier. So that didn't seem to be a predictive marker or a risk factor for not getting this benefit, I should say. And we know that cilta-cel is also approved not only for late relapse, but also early relapse, those that have as early as 1 prior line of therapy. And this was based on the CARTITUDE-4 phase 3 study that we had open here. And this is based on the PFS as well as an OS benefit, as you can see. And they randomized patients to either cilta-cel or standard of care. And in this particular study, the major agent or regimen that was used as a comparator was the daratumumab, pomalidomide, and dexamethasone. And this is actually the first CAR T in myeloma that has an OS benefit in this situation. So I showed you a lot of great things about CAR T-cell therapies, but what about the toxicity? Now, we've heard a little bit about some of the toxicities from Mike. We have this cytokine release syndrome and ICANS, which when these agents first started, coming into our clinic, we were a little bit concerned, but we're actually a lot better managing these therapies. They are predictable and treatable and reversible. What about prolonged cytopenias? About a third of the patients in those studies had this kind of prolonged cytopenia that lasts longer than 3 months. And it is a nuisance for patients, but we are able to support them with transfusions and growth factors. So it is okay, it's manageable. And infections are still an issue for our myeloma patients, but again, we use preventative strategies and mitigation strategies. So I would say these are typically treatable and manageable, and I'm not so concerned about them. But what I am concerned about are these other unusual delayed neurotoxicities that we saw with cilta-cel, specifically Parkinsonism and cranial nerve palsies. Now, both of these, the etiology is not entirely clear. And cranial nerve palsies can be bothersome, certainly to patients, especially if they come in with bilateral facial nerve palsy and they cannot talk or eat very well, but they are typically reversible with some steroids and IVIG. But I can't say the same for Parkinsonism, which is, for those of you who don't know, patients really develop symptoms like Parkinson's disease, but it's not, it does not respond to anti-Parkinsonian therapies, and it's usually not reversible. And it's really a challenge, even though these occur in really a small percentage of patients. So with that in mind, I want to talk to you about another BCMA-directed CAR T-cell therapy called anito-cel. And this was presented at EHA around the same time that ASCO was going on. And you can see here, Sorry, oops. Where am I? I gave away the answers. So you can see that while the intracellular co-stimulatory domain is similar with the 4-1BB as the other CAR-T products in myeloma, the extracellular domain is the smaller D domain, and it does allow for high CAR-T expression, less tonic signaling, and fast off rate from the BCMA target. So perhaps mitigating some of the toxicities. So these are the results from Imagine-1, which was a phase 2 study using anito-cel in the late relapse. And the median follow-up is not a lot, it's about a year, but this is what we have. So just to give you a little background on the patient population, the median lines of therapy was 3. However, what's more important in myeloma is actually what drugs you're refractory to, and 100% were triple-class refractory, which is our kind of best therapies that we use up front, which is immunomodulatory drug, proteasome inhibitor, and anti-CD38 antibody. About 40% had high-risk cytogenetics and 15% in extramedullary disease, and they were looking at the overall response rate. And look at that, 97% overall response rate, which looks really identical to what we saw with cilta-cel. Now, I'm not comparing two studies, but I'm showing you the numbers here so you're aware. And also a good portion of those patients had deep responses. And when they looked at the PFS at estimate at 1 year, most of them, about 80%, remain in remission. So clearly we need a longer follow-up. But what I do want to point out is the toxicity profile was very encouraging. So this is looking at the CRS and ICANS in anito-cel and cilta-cel. Again, I'm not comparing, but I just want to point out it certainly doesn't seem higher. I cannot say much, I wouldn't read too much into this because patient population is a little bit different. But again, I don't see any signal for higher toxicity in this particular agent. But what I do want to highlight is that there were no patients that had Parkinsonism or cranial nerve palsy, which to me is very meaningful. And one might argue, well, maybe we need longer follow-up to see if these develop. But I would say most of these do develop within the first 6 months of therapy. So I think we do have a good amount of follow-up. Yes, we definitely need more patients to be treated. But I will say they had a phase 1 study, and still they did not see these earlier. So with this, it will likely be FDA approved within the next year. So something that's going to be probably coming. What is next on the horizon in myeloma and this T-cell redirection therapy? So I spoke to you a lot about BCMA-targeted therapies. We do have other targets like GPRC5D, and we do have a bispecific that targets this called talquetamab. But what we're thinking now is why not combine targets? Why don't we target 2 proteins? And there's a lot of rationale for that. First of all, there's different expressions of BCMA and GPRC5D within myeloma cells in each patient. And these are bars of each patient. And you can see the percentage of plasma cells or myeloma cells expressing only BCMA, GPRC5D, or having both expression. So perhaps you're going to be able to capture more responses, but also avoiding antigen escape relapse, which is a problem we see. So several strategies to combine these targets. One is using 2 bispecific T-cell engagers, and there is something called the Redirect study that has really nice preliminary efficacy data here. This was presented before, a few years ago, and you can see a good response rate even in extramedullary disease, which is very difficult to treat. Now we also have a dual target CAR-T that's open here and accruing, and what I want to talk to you about is this tri-specific, which is a J&J product, 5322, and it has 3 kind of binding domains to the CD3 on the T cells, and BCMA and GPRC5D, and this is the phase 1 in late relapse. You can see here a median of 4 lines of prior therapy. 53% were triple-class refractory, and importantly, 20% received prior BCMA-directed therapies, which is the population we're seeing more and more, so we need to understand response rate in those patients. About 30% at high-risk cytogenetics and 10% extramedullary disease. And then we're looking at the recommended phase 2 dose here, and of course, efficacy as well. So let's briefly look at some of the side effects. So CRS and ICANS seem pretty treatable, respectable. CRS grades were only 1 and 2. I'm not concerned about this. No ICANS. Grade 3 infections or higher are still an issue in our myeloma patients getting these T-cell redirection therapies, specifically T-cell engagers. So 30%, a little bit lower than what we see with the BCMA-directed T-cell engager, a little bit higher than what we see with the GPRC5D-directed T-cell engager. And I want to focus here a little bit on some other side effects. GPRC5D is also present on hair follicles, nails, and acrine glands. So we get this oral side effects, dysgeusia with taste loss and taste change, and also skin rash, skin peeling, dry skin, and nail dysmorphic. So with the GPRC5D alone, so that's with talquetamab, you see that the taste changes were seen in about 70% of the patients, with about a third of the patients having significant weight loss. Now, we did not see really weight loss with the tri-specific, and a little bit lower, perhaps, taste changes. And I would say this is probably the most bothersome for patients and why someone might not want this kind of drug. But this seems to be less, or perhaps if you're targeting 2 proteins, you're having a little bit more specificity of the T cells going in the right direction and not doing any on-target, off-tumor side effects. I would say the nail and skin changes are not dramatically different, but again, the taste is most important for the patients. So now let's look at the efficacy here, and it's divided between those that had a prior BCMA, and a few of those also had GPRC5D therapies, and those that are naive. And you can see the response rate are clearly higher in the naive patients, and in the recommended phase 2 dose, it's 100%, which is really great. And then if you look at the median, the PFS in these BCMA and GPRC5D naive patients, and here in red, you see those at the recommended phase 2 dose, and in black, those that had all doses. Really nice percentages of patients remaining in remission at 1 year, 95% at the recommended phase 2 dose. So this is really promising. Of course, we need longer follow-up, but we have a good strategy here. So just to close, I showed you that BCMA-directed CAR T-cell therapy really changed the outcomes of relapsed patients. We do have an up-and-coming another BCMA-directed CAR T, anito-cel, that offers potential for durable responses, and it does have a favorable toxicity profile. We need some longer follow-up, and targeting 2 proteins as opposed to 1 is something people are looking at, and it might capture more responses and avoid relapse. I would say there's a lot of questions in the field. Should you start off with 2 targets, or should you sequence? We don't really know the answer, but we will have a phase 3 study here in late relapse comparing the tri-specific to a bispecific, just the BCMA. So a lot of exciting things.